Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
So good morning, good evening, and good night to everyone who has joined us for this edition of the Medscape Global Oncology. Today, we're going to talk about current and future oral SERD strategies in patients who've got ER-positive, HER2-negative metastatic breast cancer. We're going to really be deep diving into the clinical data, especially what has been presented at San Antonio, fresh off the hot press. My name is Shahina Dawood, and I'm a consultant medical oncologist coming to you all the way from the sunny and very nice weather United Arab Emirates. And I'm joined today by Komal Jawahiri. Komal. So in this program, we'll be talking about the mechanism and definition of endocrine resistance, going through some treatment algorithms, really incorporating all the newer treatment strategies that we have for patients with metastatic ER-positive, HER2-negative metastatic breast cancer, looking at some of the recent data for oral SERDs, looking at monotherapy versus combination therapy, and also looking at the treatment algorithm and future direction. And so past decade has been truly exciting because we know that the introduction of CDK4/6 inhibitors has basically changed the landscape of patients with ER-positive, HER2-negative MBC, especially in that first line setting where we know it has improved progression-free survival as well as overall survival with the combination of CDK4/6 inhibitors and endocrine therapy. However, ultimately, endocrine resistance will develop. Now, we know that there's so many key components that influences the journey of a patient with HR-positive, HER2-negative MBC, and it's been a fantastic couple of decades because there's been so many newer drugs that have come into play that has improved the prognostic outcome of patients by allowing us to overcome endocrine resistance. Now, can we target the PI3 kinase AKT pathway? Simple answer is yes. We know that 40% of these patients have a mutation in the PIK3CA pathway. 5% have PTEN alterations, 5% have AKT mutations. Now, Komal, before we deep dive into the oral SERD, phenomenon that's happened in the last couple of years, what are your thoughts in terms of targeting the PI3 kinase pathway? How important is that for patients, especially in that early recurrence? Because I know you presented some very important data last year regarding that.
Yeah, no, I think that's a very poor prognostic group of patients, Shahina. I think, patients who recur on or within 12 months of their endocrine therapy, the so-called endocrine resistant tumors that also harbor a PI3K mutation, when we looked at their progression-free survival, that's really, really dismal. It's like 7 months, which is very, very, poor prognostic, as you can tell, in the first-line therapy. And so adding inavolisib in such a setting to fulvestrant and palbociclib, so a triplet regimen, for the first time targeting this pathway not only yielded a progression-free survival benefit, which is now 17 months with longer follow-up, but also an overall survival benefit with a 7-month delta of improvement. And what was very starking was as early as 6 months in the landmark analyses in the overall survival curves, only 10% or 10% were dead in the control arm. And this tells you how poor prognostic this group can be. So I think very, very important for us to thinking about testing in this early setting and offering patients a triplet regimen to avoid bad outcomes in their first line metastatic setting.
Absolutely. And I think one of the highlights of the study that you presented and what you've just said right now, that it's important to test as early as possible, especially looking at those biomarkers, not only PIK3CA, but as well as ESR1 mutation. And that's where we're going to ask the question, how have oral SERDs overcome the resistance acquired by the presence of an ESR1 mutation? We know that ESR1 mutation actually is a mechanism of endocrine resistance. And I won't go through this slide in detail, but in essence, if you've got an ESR1 mutation, that estrogen receptor pathway is always switched on. We know that in patients with early stage breast cancer, the presence of an ESR1 mutation is practically nil. But as patients develop metastatic disease and they get treated with aromatase inhibitors and multiple lines of endocrine therapy, the percentage of these patients who develop an ESR1 mutation actually progressively increases. We've had a number of clinical trials that have looked at oral SERDs monotherapy, Emerald that looked at elacestrant, Serena 2 that looked at camizestrant, and of course your trial, Komal, that looked at imlunestrant in AMBER 3. And all three trials, very similar. When you use monotherapy, oral SERD in that first line setting, it is better than physician choice of endocrine therapy when you have an ESR1 mutation, especially when you're comparing it to fulvestrant. But all three trials have that rapid drop in the Kaplan-Meier curves in the very beginning, telling us that there are some patients that are completely endocrine resistant. And of course, prior use of CDK4/6 inhibitor in terms of the duration of use can predict for endocrine sensitivity. So the longer you have a prior CDK4/6 inhibitor use, the better the prognostic outcome with that oral SERDs. And it looked like, at least from Emerald, it didn't matter whether you had those co-mutations, it still worked in terms of oral SERD monotherapy. But Komal, last year and then this year, you presented, I think, a very innovative study looking at oral SERDs. It was the AMBER 3 trial that randomized patients to imlunestrant versus standard of care endocrine therapy. And then you added on that third arm that looked at combination of imlunestrant plus abemaciclib. I'm not going to go through the data. I want you to tell us, what did we see? Because you presented the update this year at San Antonio.
Yeah, no, I think very, very important. So hazard ratio is 0.62. And with this additional 14 months of follow-up, the progression-free survival is sustained. So as we know, based on these data, imlunestrant has achieved FDA approval as of September 25th in the United States. And it's nice to see that with additional 14 months of follow-up, this PFS benefit is sustained. The hazard ratio is 0.62. We also saw a overall survival benefit, and so now we're seeing a 11.4-month numerical improvement. Now, given only 2 out of the 3 arms met their PFS endpoint, very little alpha was passed on to the overall survival benefit, which is why despite the p-value being 0.0043, it did not cross the pre-specified boundary for significance. But I think numerically, we would all agree that 11.4 months with a single agent endocrine therapy is very attractive data. And the curves that you were referring to of the 3 trials from Emerald, Serena 2, and Ember 3, that 40% drop off in the beginning, which causes progression on monotherapy, really wants us to believe that combinations are the way to go, that we need to do more than what we can do with just single agent endocrine therapy. Lo and behold, when you combine abemaciclib with imlunestrant in all patients, regardless of mutations, we now, with additional follow-up at 25 months, are seeing an extended duration of a benefit of PFS at 10.9 months with the combination compared to 5.5, hazard ratio is 0.59.
So,
And
Komal,
also, yeah, I was just going to finish my thought that,
Yeah.
65% of the patients on this study had been on a prior CDK before they went on this doublet arm. So that's majority of the patient population. Even in that, we still see a 9.1-month improvement. And for patients with ESR1 mutations, it's even better. The combination yields even more than what single agent did with 5.5 months. It's now 11.1 months. And I think that's very difficult to ignore, that it's 11 months for the combination. Similarly, we've also seen the benefit in ESR1 wild type with extended follow-up and PI3K mutant tumors. Again, benefit has been seen with imlunestrant and abemaciclib, regardless of those biomarker status.
Absolutely. So I'm going to ask you a very important question, Komal, here, and that's what I was trying to ask earlier on. We know the FDA has approved imlunestrant on its own as monotherapy. We've repeatedly shown that drop in the Kaplan-Meier curves, and I'm not going to go back to the slides. You can see that drop. There are a group of patients truly endocrine resistant, truly not going to benefit from anything that you give them, but that drop off is reduced with the combination. What do you think is going to happen in the community? I'm a community oncologist. What do you think I should do and what I should be offering my patients if everything was available?
Yeah, I think, that's a very, very important question. So it's in a way, a good thing. The good news is we have more options. And then the challenging news is we have more options. How do we use them and how do we sequence them and how do we optimally offer the right treatment to the right patient at the right time? And that's where, again, the art of medicine will still come into play, and it cannot be just one size fits all approach. At the end of the day, we're going to look into what was their prior therapy, how do they respond to the prior therapy, what do we know about their disease burden now, what is important about their biology that we learn and know about. We want to understand the administration schedules. For instance, we will talk about Victoria 1, and that has some data in pediatric wild type. That has three drugs, one intravenous, one intramuscular,
Yeah.
one oral. We have two oral drug options from Ivera and Ember 3 that we will talk about as well, right? And so it'll depend on the administration schedule, it'll depend on the toxicity profiles, and ultimately will have to be a patient physician decision making process. The good news is two drugs work better than one. We have more than one option potentially going to be available very soon for our patients. We just need to discuss this with our patients the way it is, evaluate it, and offer them.
Absolutely. And as Komal has rightly pointed out, we are going to face patients as we test more and more and we test early enough. These patients are going to have a significant portion of them are going to have co-mutations like a combination of a PIK3CA mutation and ESR1 mutation. We have seen efficacy of oral SERDs in those patients with co-mutations. We have data from the Emerald study that's telling us elacestrant works in those patients with co-mutations. We have data from the Amber 3 study, which also tells us that it works in those patients with a co-mutation. Now, as Koma mentioned, we have seen data. This comes hot off the press as well from ESMO this year. We saw the results of the Evera study that looked at another oral SERDs. All patients had received a CDK4/6 inhibitor. These patients were then randomized to get either giredestrant plus everolimus versus standard of care endocrine therapy plus everolimus. And what you see is in those patients with an ESR1 mutation, again, that drop off is partially at least overcome, and you can see an improvement in the PFS from 5.45 months to 9.9 months. In my mind, a good combination, probably a cheaper combination than combining a CDK4/6 and an oral SERD, but certainly an option for our patients. We saw a very nice slide at ESMO actually telling us that with combination endocrine therapy, you are able to cross that 6-month PFS barrier that we've been stuck on in terms of trying to improve prognostic outcome for our patients. Now the question comes, if combination endocrine therapy works and it works very well in those ESR1 mutation positive tumors, could we potentially look at intervening early? For example, when we are having our patients that we typically tend to see in the clinic, you give them an AI plus a CDK4/6 inhibitor. At radiological progression, you actually change your endocrine therapy, and then you change it again at the point of next radiological progression. Perhaps what we need to do is at that point of molecular progression, at the time that an ESR1 mutation actually develops, you switch at that time before radiological progression. And when you switch at that time, the hope is that you'll have a longer PFS. You delay radiological progression, you delay the time to chemotherapy, and you allow early intervention before patient drop off. And this was certainly the reasoning behind developing the Serena 6 study. These patients at molecular progression, at the time an ESR1 mutation actually developed without radiological progression, was switched to either continuing the same AI plus CDK4/6 inhibitor or switching to camizestrant plus the same CDK4/6 inhibitor. And what we saw was a very nice separation, the Kaplan-Meier curves, where the PFS improved from 9.2 months, 16 months, something that we hadn't seen before. And essentially, this is what I want to highlight, those rapid progressors, the drop off that we were seeing a lot of in the oral monotherapy, oral SERDs, and then partially when you gave combination at the radiological switch, we're not seeing it at Serena 6. What are your thoughts, Komal, over here? How do you think that it will go for our patients in the clinic? What is the community?
Excuse me. Yeah, no, I think this is very interesting because we want to try and see, can we do things earlier? And that's not a novel question in many ways, right? It's just that the technology is new. So nothing new about this concept other than the technology is now evolved. We want to stay in times with this technology. And can we really do this for our patients where we can tell them, we're watching your tumor biology very closely. We're trying to see what's happening in the tumor. And if something happens, we want to try and intervene early, even before you get those symptoms. Now, in all fairness, these patients developed ESR1 mutation, the median time was about 23 months. We know that they stay on their CDK4/6 inhibitor in the first line setting for about 27, 28 months. Despite identifying in the 23 months, control arm still stayed on therapy for 9 months. So there are great questions addressed with this. There are a couple more questions that we still want to address with respect to overall survival. Ultimately, our goal is by doing this, are we making the patients live longer? Or are we just giving them better therapies sooner? Certainly, we're making an impact on their quality of life, and that's what Serena 6 definitely be showed. And I think that's very meaningful for our patients. Many patients would offer that. So I think this is one additional strategy. Is it perfect for everybody? Is it perfect for everyone to do this? I'm not sure yet. I think, but it's worth discussing, and a patient can decide if this is how they want to proceed with it.
As a community
Yes.
oncologist, there's so many questions that we will be addressing. As you know, Komal, Serena 6 has actually been approved in the United Arab Emirates and is being planned to be launched in 2026. And one of the questions that's come up is, if we implement Serena 6, how often should we be testing for an ESR1 mutation?
Exactly. And so that's a very important question. Before you get there, there was one question that came in the audience that caught my attention. Question about when would we do monotherapy, when would we do combinations? Fantastic question. When you have patients who've done really, really well on their first line therapy, who have very endocrine sensitive disease, you then detect just an ESR1 mutation. There are no other co-occurring mutations. The disease burden is not necessarily overwhelmingly high that makes you nervous for your patient. I think that patient very, very appropriately can be treated with monotherapy. We all know, though, that there are many patients who have things beyond that, right? And so that's where we are thinking about combination. So when you have more disease burden, maybe you don't have the first line CDK, responding to the great benefit that you were hoping them to respond. That's when you're thinking more about combinations. I think even in such cases, if there is no contraindication to a CDK, there's no barrier to taking it, the 11 months from EMBER-3 still makes me feel like combinations are a way to go, but that's a discussion you can have with the patient. So it
I,
depends on the age, comorbidities, tumor burden, and that's how you decide mono versus doublet. Going back to your question about,
yes.
Serena 6 is now rolled out, and how do we test and how much should we test? As I said, median time to detecting was 23 months. 50% detected it at the first time they ever tested. So do we really need to start testing right from the beginning? One could potentially argue maybe we could wait and maybe even, start a little delay than the trial did, just to make it simple and easy for, us monitoring that. And certainly would depend on a patient that is again in front of you, the disease burden and symptoms they might have. Sometimes you have rising markers and you don't know what to do. And that could be a very appropriate patient where you can find this and see if there is a rising ESR1 or a new emerging ESR1. So I don't know if I will start for all patients at 6 months. For the patient who is interested in such an approach, I might be okay waiting for a year or up to 18 months and then start thinking about it, just because the median time to detecting it was longer than the first line.
There's so many exciting questions, and we know there are a number of trials that are going on right now that's going to just make life more complicated but better for our patients. You've got the Pioneers trial, which is also looking in those patients with ESR1 mutation, randomizing patients to giredestrant versus fulvestrant. You've got the Persevera trial and the Serena 4 trial, because if these trials are positive, we may not even need to test for an ESR1 mutation up front, where you can just use an oral SERD. And I'm not going to go through this in detail because we've got so much more to discuss. But when we start using oral SERDs, there are going to be different side effects that we will have to learn how to deal with and educate our patients. And in this slide, you can see a snapshot view of the different side effects that we potentially might encounter as oncologists. Now, how will we use oral SERDs in the EBC setting? How will this use impact the metastatic setting? The reason why I asked this question is because this year at San Antonio, we did see the results of the lidera study that took patients stage 1 to stage 3 early stage breast cancer, randomizing them to either giredestrant versus standard of care endocrine therapy in that early stage breast cancer setting. And what we saw was a very impressive improvement in the IDFS. And you can see, for me, this looked very similar to what we saw when CDK4/6 inhibitors first came out in that early stage setting. A nice separation of Kaplan-Meier curves, hazard ratio of 0.7, 30% reduction in the risk of recurrence of disease when you gave an oral SERD versus if you gave endocrine therapy, a standard of care endocrine therapy. And I know there's so many questions around that, but we do need to push on. And I will come back to that as we go through the algorithm. But my next question is, in the absence of a biomarker, we talk about ESR1, we talk about PIK3CA, we talk about so many other biomarkers, but what do you do when a patient with metastatic breast cancer has no biomarker? Well, again, Komal just alluded to this. In the AMBER-3, the combination of imlunestrant plus abemaciclib worked, and it worked very well in those patients who did not have an ESR1 mutation. We've also seen at ESMO this year the results of the Victoria trial that took patients who are wild type for PIK3CA. These were metastatic patients, hormone receptor positive, HER2 negative, who'd progressed on a prior CDK4/6, randomized to either triplet regimen of gedatolisib, palbociclib plus fulvestrant versus the doublet of gato plus fulvestrant versus fulvestrant alone. Very impressive results, I think. When you use the triplet, you get an improvement in the progression-free survival from 2 months to 9.3 months. And if you used the doublet, you get an improvement of from fulvestrant 2 months to 7.4 months. We've also seen the results this year at San Antonio, the Elevate study, which again took patients who had progressed on a CDK4/6 inhibitor. These patients were given elacestrant and then combined with different agents. When you looked at those patients where they got elacestrant plus everolimus, a very impressive PFS of 8.3 months, and this is across all subgroups, irrespective of the type of biomarker that they had. And then you had the combination of elacestrant plus abema, again, an impressive median progression-free survival of 14.3 months. So before I go into the algorithm, because I want to spend some time on this, Komal, if a patient comes to you in the clinic with metastatic breast cancer, hormone receptor positive, HER2 negative, they're all going to get a CDK4/6 inhibitor in the first line setting. In the second line setting, if they have no biomarkers, how should we approach these patients?
Yeah, I think it'll also depend on what drugs become available to us and what combinations get approved and are available in our arsenal for us to pick from. But short of, so if we did not have Evera, if we did not have Ember-3, and if we did not have the Victoria 1 trial, right now what we were doing is we were looking at everolimus with endocrine therapy and abemaciclib with fulvestrant, specifically due to the post-Monarch trial that had shown us the 6-month improvement in benefit compared to 5.3 months with fulvestrant alone. So we used those two. Depending on what happens with Evera and Victoria 1, we might have those options available with a novel endocrine backbone. The Victoria 1, as you pointed out, is an interesting one. Certainly, we'll have to see if the triplet gets approved and the doublet both get approved, because as you recall, the triplet is compared to fulvestrant, the doublet is compared to fulvestrant, but the triplet and the doublet are not compared to each other. So it's hard to know exactly how much more, the triplet is offering on top of the doublet, right? And it does have the slight complication of having 3 weeks on, 1 week off intravenous therapy, 1 intramuscular injection every 4 weeks, an oral drug. And the triplet did cause a 19% grade 3 stomatitis despite dexamethasone mouthwash. So not very trivial in a second line population when they have to come to the center continuously every week and have toxicity. So I think, again, it would boil down to how are we thinking about these options? What are these options? What are the comorbidities in front of us for our patients? And discussing the toxicity profiles and their preferences would become very, very important.
So I want to spend the last couple of minutes on this algorithm. Now, this algorithm assumes that nobody's received a CDK4/6 inhibitor in the early stage setting, which is probably not going to be true in the next couple of years. You've got patients who have recurred more than 12 months after completing an adjuvant AI, or less than 12 months completing an adjuvant AI, and then getting their medications with a CDK4/6 inhibitor at that recurrent setting. Upon progression of disease, we profile all the tumors of all patients, and we look at those different biomarkers and we treat them appropriately. Now, I'm going to try and place, and Komal, please help me place this here. One, where are we going to put Amber? And this is where we've put Serena 6, and then I'm going to go to Amber. Serena 6, we said, probably would come somewhere here after first line CDK4/6 inhibitor in those patients who have a long treatment free interval and then recur. And of course, all those patients with stage 4 de novo, when they do progress, perhaps those are the patients where we would add Serena 6. What are your thoughts here?
Yeah, no, I think, for Ember 3, we got the monotherapy approval. We have, the sponsor now has submitted the doublet paperwork to the FDA, and hopefully very soon we'll see guideline endorsement as well. So certainly for the ESR1 mutant patient population, I feel like that is one thing that we can certainly consider. Based on the approval and the guideline endorsement, maybe we could have hands on abemaciclib and imlunestrant even for the wild type tumors and potentially use that as an option. Serena 6, I think, would be again a discussion with the patient where they would be okay with monitoring, okay with understanding that we don't have an overall survival benefit right now, but potentially something that we can follow and they can have a good quality of life and monitor. Because we do have these doublets at the back end, so we don't know if an upfront strategy like Serena 6 is really overcoming all the PFS that we're going to see with the doublet 10 months, 11 months, and actually making a patient live longer. So I think it's a strategy. We don't know if it's the strategy for everybody.
So I put Amber 3 in these different boxes. Would you agree with what I've put in those patients with an ESR1 mutation, those patients with an alteration of the AKT pathway, those patients with the PIK3CA mutation by itself, and of course those patients with no actionable mutation? I think the combo is
Yeah.
probably where we're going to put Amber 3
Yes. I would
in our
say short
strategy.
answer is yes. The data are giving me this reassurance that yes, I can do all of this. What
And do
the
you think
regulatory agencies will do is a different
that's
scenario.
different? That's a different
But
matter.
clinically, I agree with that.
And do you think giredestrant plus everolimus, if approved, would be somewhere here?
It would definitely be in the ESR1 mutants. While the benefit was also seen in the IIT, we can see what happens with its availability for all comers, regardless of
Of
the
course.
mutation. Including for the PI3K mutants, we know everolimus can work regardless of a PI3K mutation. And they showed the subgroup analyses at San Antonio where a very good PFS was seen even in the PI3K mutant. So I think it's very important.
I just want to give some key takeaways. It is important to recognize that not all patients do the same in their journey with MBC hormone receptor positive. They're not the same also in terms of their endocrine sensitivity at every time point. I think we've illustrated that. We have to define, recognize, and appropriately use biological profiles. All patients should receive a CDK4/6 plus endocrine therapy in that first line setting with or without inavolisib if they're in that certain category of patients. Post CDK4/6 inhibitor progression, your treatment will be guided by the presence or absence of biomarkers. We will need to rethink, I think, our definition of endocrine resistance and sensitivity, because I think it's a definition in evolution. It'll be important to start to test for biomarkers early and making it part of our regular practice. And please don't forget to consider the patient profile, the toxicity profile, patient choice. And when considering any therapeutic strategy, patient choice is key. Komal, any last words before we log off?
I think it's an exciting time in oncology. We definitely have a lot of options that are coming in the treatment armamentarium. I think it's going to really be very important to understand how we can keep patient preferences and the benefit that we want to offer them first. Make sure that we understand their comorbidities, make sure they understand the toxicity profile, and then toxicity management, very important with combinations. You definitely see efficacy, you definitely see toxicity. We need to know how to address them very well for our patients.
Absolutely. So thank you everyone for coming on board for this edition of the Medscape Global Oncology. I hope you found it as interesting as we have. Exciting times, brilliant data. Next year is going to be even more exciting and also more complicated. So thank you all and thank you, Komal.
Thank you.